In this class we will discuss regarding the surgical management of pterygium, the indications of surgery, excision of pterygium and the closure techniques of pterygium. Now coming to the indications. So one is the proximity or encroachment of visual axis. So it has come over the pupillary area and it is causing significant astigmatism. It is more than 2 diopters. There is extraocular muscle restriction leading to diplopia. There is atypical appearance like dysplasia. There is symptomatic, that is pain, redness, watering, or there is cosmetic concern. So these are the indications of surgery. Now coming to the surgical techniques. So we have to remove this pterygium, right? So this pterygium is slowly removed, and this area which is removed is either left like that or it is closed, right? So that's why we have excision and closure. So these are the two main things which we need to consider. So coming to the excision of pterygium, it can be with the help of avulsion method, so in that what we do is the body is dissected from the underlying sclera, and then avulsion of the head is done by grasping with forces and applying contraction from the cornea. Understood? So first it is removed from the sclera, and then by pulling it from the cornea it is removed. So that is avulsion method. And another is superficial keratectomy. So this is the opposite one. So dissection starts from the head of the pterygium, and it is slowly done with the help of keratome, and then the body and all is removed. Okay, so here the body is first removed and here the head is first removed. So this is superficial keratectomy method. So here the cornea is more smoother in case of superficial keratectomy. Now coming to the closure techniques. So in earlier days they used to do bare sclera, that is they did not close this, so they just left this area like that. Okay, so that is called as bare sclera. That means the sclera is visible. So we have removed the pterygium, the underlying tenons and the subconjunctival tissue, right? So only the sclera is removed after, sclera is visible after that. So that is called bare sclera technique. So it has high recurrence rate, that is 30 to 80%. And in some cases what they did, so the remaining, the conjunctiva is there now, so that conjunctiva is closed, so that is simple closure. In this also the recurrence rate is very high, that is 30 to 80%. So that's why we have developed newer techniques of closure. So we will discuss one after the other. We have sliding conjunctival graft. So in this, a pedicle graft or a sliding graft from the superior or inferior conjunctiva is taken. Okay, so it is attached instead of complete removal. It is just taken. I'll explain you better. So from the superior area this conjunctiva is taken, or the inferior area the conjunctiva is taken and closed. So this is sliding conjunctival graft. Then we have conjunctival autograft. So when the limbus is unhealthy, we will just take the conjunctiva autograft. Instead of from the limbus, we will take just the conjunctiva. So it is done when the limbus is unhealthy. So it has also a high recurrence rate, about 30 to 40%. In sliding conjunctival graft, the recurrence rate is less, that is 7%, and less complications. Then we have conjunctival limbal autograft. So because in the etiologies we have learned that there is limbal stem cell deficiency, so that's why we are taking limbus from the other side, and that limbus is placed near the limbus of the pterygium side. Okay, so usually the graft is taken from superior temporal, bulbar, limbal conjunctiva. So if we consider this as the eye and this is the nasal side, so we are taking a graft from this side, so that is superior temporal. So this is the graft along with the limbus which is taken, and this is then placed in the area where the pterygium is removed. And this conjunctiva from here, so this area conjunctiva we have removed, right? So we will just do it a simple closure. Yani we will just pull it and then close it. And here we will attach it with the remaining conjunctiva by putting sutures or fibrin glue. Then we have conjunctival rotational autograft. is done in cases of extensive pterygium, double pterygium or previous glaucoma surgery, when the conjunctiva is not much available to do a autograft, right? So here what we do is that, so the conjunctiva from the body of pterygium is taken, it is stored in the saline and then sutured with the scleral bed. Then we have pterygium extended removal followed by extended conjunctival transplant. So this is perfect. That is pterygium extended removal followed by extended conjunctival transplant. So it was described by Dr. Hist from Australia. So here the recurrence rate is almost 0.5%. In the limbal autograft, the recurrence rate is almost 3 to 30%. So, but it is comparatively less. So this is also the good technique. So we have this conjunctival, limbal autograft, sliding graft and the perfect techniques which have very low recurrence rates. So in this what we do is that extensive conjunctival autografting is done. So this graft is very large. So in this a very large graft is taken and a very large pterygium is excised. Okay, so here the scar and the graft edge, everything is inside the fornices. That's why it has a better cosmetic outcome. But the disadvantage is that it is technically challenging, time consuming and painful. Then we have cultivated conjunctival grafts. These also have a higher recurrence rate. Then we can take in cases of dry disease, we can also take graft from other surface. So these are all autografts. So here we are taking conjunctiva from the same person. So we can also take other grafts like a buccal mucous membrane graft or amniotic membrane graft, right? Amniotic membrane graft. So we'll just have a brief overlook of amniotic membrane graft here. So it is an innermost semi-transparent layer of the fetal membrane. Here it has anti-inflammatory, anti-scarring and anti-angiogenic properties. That's why it is used either fresh or preserved. So here the recurrence rate is also very low, so that is 3 to 10%. So it is useful in cases of white pterygia, multiple heads, and when the enough tissue is not available. So this is also a good technique. So now, so how do we attach this? So here one is this, we have attached this with the help of sutures. So either with the help of sutures, with the help of autologous serum. So in this, the patient's own blood is used, and there is fibrin glue. So in the fibrin glue, while placing the fibrin glue, it is a very good technique. So here there is less pain, less time and inflammation, because suturing and all takes a lot of time, and this serum, autologous serum, may be lost, or they can be graft displacement and all. So here we have fibrinogen part and the thrombin part. So fibrinogen part is applied on the graft, and the thrombin part is applied on the bare sclera. Okay. So now what do we do to the cornea? So in these cases in which a large part of the cornea is involved, we can perform laminar corneal transplantation. So in which we have to thicken the cornea, because the cornea has become very thin in these cases. So for the cornea, we can perform lamellar corneal transplant or graft, and we can perform keratoplasty or sclerokeratoplasty or barrack or polishing technique. Etc. to maintain the corneal integrity, right? So this was regarding the treatment, that is surgical management. In the next class we will discuss regarding the adjuvant treatment with antimetabolites or irradiation like that, and also we will discuss regarding what are the strategies to reduce the recurrence, the complications. Thank you.